So let's start with the next talk, which is about post-keratoplasty situations for IL power calculations.
The oracle has spoken.
Good morning, everyone. So I'll be talking about the IOL calculation and penetrating keratoplasty or keratoplasty situations. So the patient data which I am using in this particular presentation are the patients which I had operated at LV Prasad when I was there till about 2 months ago. So this is a patient who is a 63-year-old male patient and had a decreased vision in the right eye following a corneal scar which he developed after keratouveitis, HSV keratouveitis. So we operated the patient, did a routine biometry for him, and if you see here, the K reading which has been taken for him is a standard K, which is 44 diopters. So with that, the IOL power which we were getting is about 21.5, and that was used for the patient. And post-operatively, the patient had a good vision, 20 by 125, improving to 20 by 80 with pinhole. 6 months later, the vision dropped to 20 by 30, and this is the refraction which he had, minus 10 sphere and minus 12 cylinder. And this is the pentacam. As you can see, the keratometry is 48 and 55, much more than what we have input, that is the standard K, which was 44. So what basically we are trying to say is a standard K of 44, which we have been using for decades now, is probably not the ideal way to deal with IOL power calculation for the patients who are due for penetrating keratoplasty. So a triple procedure was started in 1976 by Taylor and is still being used. But studies have shown that the intraoperative risks are higher in triple procedure because you are doing an open sky procedure, and also the IOL power estimation which you end up with can give you results as varied as in this particular study, about minus 15 to plus 8 diopters. That kind of a variation is what you get after the surgery, a triple procedure. So probably this is time that we probably have to look beyond a standard K and maybe move beyond or further than the triple procedure. So some studies have actually used a pre-op K. I mean, when you have taken go for a eye donation, you do a on the diseased person, you do a keratometry and use that particular K when you are doing a IOL power calculation. However, a more ideal situation or more practical situation would be doing a sequential procedure. There are many studies which advocate that now. So in this particular studies, 22 patients had a PK done, and later on ECC was done later on using a more predictive IOL power calculation, and then they found that the 95% of the patients were within plus or minus 2 diopters of their desired value. So similarly, like when you are doing a triple procedure, your options are either you do a sequential procedure, beyond a triple procedure, your options are either you do a sequential procedure, or there is an option of what we call a mixed procedure. That is, you do take out the cataract, but later on put the IOL. In the sequential procedure, a PK is done if the corneal pathology is thought to be predominantly cause of the symptomatic reduced visual acuity, and the cataract is not very advanced. So let's say you can later on operate the cataract with a simple phaco procedure. The phaco procedure these days are very simple, and you do not damage much of the endothelium. So then in that situation, the sequential surgery can be planned. The sequential cataract surgery can be planned after about 6 to 9 months of the surgery, because that is the time it takes for the corneal keratometry to stabilize after a corneal transplant. Combined approach or the mixed approach is you do the keratoplasty, remove the lens. You will be doing that in lenses or cataract which is a very dense, let's say grade 4 cataract, because you will not be able to safely take out that particular kind of a cataract in a keratoplasty patient, because that will cause a lot of endothelial damage. So it's a combined approach. You do the PK and you take out the lens and leave the patient aphakic, and then after 6 to 9 months, then you will be implanting the IOL. So this is a situation which probably will clear the issue. So in this particular patient, we did a triple procedure. Patient had an adherent glaucoma, and a standard 44K was used. As you can possibly see, the error is minus 2.5 spherical and about minus 8 cylinder. However, we try to do a sequential approach in this particular patient who had a corneal amyloidosis. So we first did the PK, and later on, about 9 months later, with the phaco, because as you can see, it's not a very advanced cataract. So here we ended up with a spherical equivalent of about plus 0.75, which is very well tolerated by the patient. These days we have, in many of the patients, we will be moving on to DSEC. I mean, where the indication is just an endothelial problem. We will not be doing a penetrating keratoplasty. So if you are doing a DSEC for the patients, then what you have to understand is, because you are adding the tissue in this particular patients, so this leads to hypermetropia later on. So it generally, more often than not, we end up with a hypermetropia of about plus 1 to 1.5 diopters. So when you are doing a DSEC along with the cataract surgery, or you are doing a DSEC and later on you are planning a phaco with the IOL, you will basically overestimate your IOL and make the patient myopic by about 1.5 diopters. Again, as the things are moving, we are now moving to DMEC rather than DSEC. So in a situation where you're doing a DMEC rather than a DSEC or a PK, then you will be aiming for a myopia of about minus 0.5 diopters, because here you're only transplanting the descending membrane. So the tissue which is added is much less, and the refractive power which is changed is very minor. So you just aim for a minus 0.5 diopters myopia. That would be all from my side. If you have any questions, I will be happy to answer.